I apologize to Richard if I'm going to overlapping on some of the topics we talked about, because I think it's very important to understand the basic principles and concepts of managing thyroid eye disease before you start talking about atypical manifestations and presentations. So you already heard about the pathogenesis. The more papers you read, the more complex it gets, the less I really understand about the pathogenesis of thyroid eye disease. But if you're going to be managing the vast majority of patients, you have to understand the history of the natural history of the Rundle's curve, where there's an active phase and inactive phase, and if you decide to intervene medically, you want to involve in the active phase of the disease, and that's where it's very important. And that is completely different from severity that Rich was really talking about. And the basic principles of management are the supportive therapy, which is the vast majority of patients, hand-holding these patients with other modalities of intervention, medical management, which again was mentioned briefly, and surgical management. So to me, if I were to make thyroid eye disease very easy, these are the only three questions you need to answer. Is it or is it not thyroid eye disease? And I'll showcase some examples. The second question you want to ask is this patient have active disease or inactive disease? Because no point throwing in steroids when somebody's got inactive disease, and that's where all the Cushingoid features we're talking about. Patients have been on oral steroids for years, and then there's actually inactive disease. The third thing is it mild, moderate, or severe disease? Because the severe the disease, the more lower threshold you have for intervention, whether it's medical, surgical, or so on and so forth. So here's examples of patients who are referred as unilateral proptosis, globe dystopia, and you can see over here, one has an axial myopia, which was not picked up earlier on. Even the patient was not aware about it, and just because he did a T3, T4 TSH, or a TRAB, or a TSI, you actually make a misdiagnosis of thyroid eye disease. This is another patient who actually was developed a proptosis. He did not tell the ophthalmologist, general physician, that he had a glaucoma surgery with a tube shunt procedure causing a down and out proptosis. That's where the first question is very important. Before you start managing them, make sure it is really thyroid eye disease. And to me, thyroid eye disease is a clinical diagnosis. It's not a diagnosis based on CT scan. It's not a diagnosis based on T3, T4, TSH, or TRAB, or TSI. It's a clinical diagnosis when supplemented with investigations really comes in handy. The second question is it active or inactive disease? And that's very important. And realize that you can have various grades of inflammation. The gentleman in the middle is somebody who in the past used to have radioactive iodine without knowing the fact that he had an active inflammatory disease and an acute flare-up as well, which we avoid nowadays by giving peri-RAI oral steroids as well. And you can see the severe degrees of inflammatory activity as well. And here, you don't want to be doing surgery on them, you want to do medical intervention, okay? Of course, you want to rule out other causes of orbital inflammatory disease. The third question is it a mild, moderate, severe disease? And examples of mild, moderate, and severe disease being sight-threatening, and to me, it's not just loss of visual acuity. Even a diplopia in primary gaze within 30 degrees of fixation, to me, is severe vision-threatening disease. If you, an ophthalmologist, had 6/6 vision in both eyes, 20/20, but had diplopia in primary gaze, to me, that's sight-threatening disease. That changes your life completely, okay? So severe disease is all these cases of severe exposure keratopathy, compressive optic neuropathy, where you want to be working on these patients urgently. And the principles of management here are active disease, depending on whether it's mild, moderate, or severe, the various forms of intervention, and inactive disease, you either symptomatically manage them, or based on the quality of life, you end up doing various interventions. Classic examples are new onset patients who have 6/6 full motility, so on and so forth. So if you look at it from a point of view of how much morbidity they have, it's really not much. But the quality of life is really affected. With high-dose avimethyl protocols, you're able to actually reverse a lot of these signs of disease. The trick is to catch them early, not late, not 6 months, 8 months, 12 months later. And when you have more severe disease, then that's when you resort to surgical intervention, examples of that. So you are now familiar with the eyelid, lacrima, the orbital, and the facial signs itself. I'm just going to talk about some atypical cases in the next several minutes. Here's a patient who actually was referred for a ptosis evaluation of the right upper eyelid. He's a bus driver who's been saying, I have difficulty driving my bus. And the ophthalmologist thinks the MRD1 is low, he's got a visually significant ptosis, gets referred to me. And what the ophthalmologist did not realize is actually a left proptosis with an inferior scleral show. So in other words, most patients are bilateral disease, but a lot of them are presenting as asymmetrical unilateral disease. And again, it's a clinical diagnosis. Then you follow it up with various investigations to confirm the diagnosis. We are also taught that severe disease have all the signs of clinical activity scores, rubor, Kaller, tumor, Dollar, functional laser. This is a patient Progressively, he was not so excited about going back to work. He works in a chemistry lab, could not even make out the colors on the test tubes and the chemicals, so on and so forth. Look at his eyes. Not proptotic, no obvious lid retraction, maybe a subtle asymmetry, and look at the apex of the orbit. Okay? So you have to be careful about the concept of silent active disease, and which we, again, in East Asians, we see quite a bit as well. And ophthalmologists miss this because they say, oh, he looks perfectly fine. Even if you tell me he's got thyroid eye disease, he's got mild disease. The third important thing is about the concept of activity looking for conjunctival chemosis. To me, I can make out a chemosis 5 feet away. Look at this glistening eye of a patient. You don't need a slit clamp to pick up the chemosis as well. And that itself tells you there's either a congestion or active inflammation. And of course, the caruncular edema, which is present in the medial canthal area, is very important. So when you have it with lid retraction, it's easy. But if you have it without lid retraction, again, you can miss these subtle clinical signs of chemosis as one of the clinical signs of active inflammatory disease. Droopy eyelids. Again, yet another patient referred to us for droopy eyelids. He said, end of the day, I just feel tired, I can't read anymore. Remember, myasthenia gravis happens in about 5 to 7% of patients as well. So when you see asymmetric disease, when you see lid retraction on one side, think ptosis on the other side, do your ICE-PAC test, antibody test, and you don't want to be operating on these patients. I just had a chat with Diego Strinis, and we were talking about how often we see SLK in our patients. I don't know. How many of you have seen superior limbic keratoconjunctivitis with thyroid eye disease? Textbooks talk about it all the time. Yes, there are about 4 or 5 hands. But actually, in reality, I don't see it as much. But for textbook sake's perspective, it's very important, because if you do not stain, and it's not fluorescein stain, it's actually lissamine green that you should be using to pick up SLK in a patient with thyroid eye disease. Here's a patient who actually comes in like that, and look at it, and he doesn't look too bad. This guy has been on anti-glaucoma drugs and so on and so forth. And when he anesthetizes ocular surface, he opens up his eyes, and lo and behold, his eye is way up there. So he's squeezing his eyes partly because of ocular surface disease and partly because of severe hypertropia, which, believe it or not, still gives him diplopia in certain cases as well. So masked clinical signs in thyroid eye disease is very important, because he may be walking down the street and you can miss it. Alan Putterman described the 11 lines. This is 111 lines over there, which is seen glabella furrosa as well as one of the pathognomonic signs of active inflammatory thyroid eye disease, basically showing how much ocular discomfort they have. We are writing a major paper now on glaucoma and thyroid eye disease is really real, and a lot of patients, believe it or not, end up having anti-glaucoma drugs. If you check an intraocular pressure with a Goldmann applanation tonometry in a patient who's got inferior rectus fibrosis, when they struggle to get your eyes in primary gaze, invariably the intraocular pressure goes up. And pressure is 26, immediately they get labeled as glaucoma. Or a patient with compressive optic neuropathy who ends up having visual field changes ends up being treated as glaucoma, and I've even had patients seen with trabeculectomies for these patients as well. So be careful about it. The last couple of points is how useful is RAPD for compressive optic neuropathy? Because this is a bilateral disease, even in the late stages of compressive optic neuropathy, RAPD may not be picked up. Hence, go for the color vision. 8% of men are colorblind, so be careful about the color vision and perimetry, and that's very important. So do not miss compressive optic neuropathy looking for RAPD. The last point is, I think Rich was talking about it, quality of life. I have patients with mild disease who have severe difficulty with their normal lives, and I have moderate disease, typically men, who are just indifferent about the whole thing. So the threshold to intervene on them medically during this phase of disease is dependent on the quality of life. Take that into consideration. So in summary, I think thyroid eye disease is very challenging, but you're on top of the ball. It is actually very rewarding when you got your diagnosis right, appropriately intervene. Be aware of both the typical and atypical presentations. I believe in the SAP of medicine, science, which is what is written in the textbooks. Then it's art, which is why Rich Allen and Diego Strinis get better results than I do. And then there's finally philosophy, because the evidence is not out there in a lot of things, including the biologics. If you believe in it, you would do it, so on and so forth. But with the appropriate techniques and knowledge and application, you should be able to get good results. Thank you very much.